study. So Dr. Pranita Sahay, she is a ex-senior resident and postgraduate from All India Institute of Medical Sciences and currently working as a consultant in Center for Sight, Delhi.
Thank you, Dr. Vikas, for the introduction, and also thank you for inviting me as a co-instructor in your instruction course. Good morning, everyone. I'm Dr. Pranita Sahay, and I'll be discussing about the HEDS study. Sorry, I have a bad voice, so please pardon me for that. So as we all know that herpetic infections are endemic throughout the world, and the high rates of HSV infection is often an economic burden. There are a lot of questions related to oral antivirals and topical corticosteroids that are yet unanswered for viral keratitis. That is what led to the advent of HEDS trial. So the HEDS study is divided into part 1 and part 2, each of which had 3 subparts, each dealing with a specific question that had to be answered. So in HEDS 1, the first one was stromal keratitis, the role of topical steroids. Second one was stromal keratitis, role of oral antivirals. And the third was herpetic iridocyclitis, the role of oral antivirals in them. So let's see each one of them individually. So the first study was herpetic stromal viral keratitis, wherein the patients were divided into 2 groups. One, all the patients at baseline were on topical antivirals, and they were classified into 2 parts. One, who were given topical steroids in addition to topical antivirals, and the other ones who were treated with placebo therapy. So now it was noted that the time to treatment failure was less in the steroid group. The failures were higher in placebo groups. However, at 16 weeks follow-up, the failure rates increased in the steroid groups. So in this study, it was seen that the topical steroids led to a faster resolution and lower percentage of treatment failures was seen with topical steroids. Looking at the treatment success, again, the median time to resolution was less with steroids, success was better with steroids. However, no difference was seen in the final visual acuity at the last follow-up. So the take point from this study was the 10-week of corticosteroid therapy was a short duration for treating stromal keratitis, because at 16 weeks, almost 50% of the patients who were on steroid therapy ended up in failure, probably because of an earlier cessation of steroid therapy. Hence, steroids may be tapered slowly in cases of herpetic stromal keratitis, and definitely steroids led to a better response compared to placebos. The second study was in patients of stromal keratitis who were already on topical steroids and topical antivirals. They were again now divided into 2 groups, one who received oral antivirals and the second who were on placebo. In this study, oral acyclovir was given as a 400 mg 5 times per day dosing for 10 weeks. It was seen that there was no statistically significant difference between the 2 groups. The failures were similar in the 2 groups, whether they received oral acyclovir or placebo. The resolution or the treatment success was also similar in the 2 groups. Hence, there was no benefit of adding oral antivirals in patients of stromal keratitis. Moving on to the third part of HEDS 1, that was the herpetic stromal viral keratitis iridocyclitis subgroup. In this, the target sample size was 104. However, adequate patients could not be recruited. In this study, oral acyclovir was compared with placebos, whether it helped in an early resolution in cases of iridocyclitis. It was seen that treatment failures were less in acyclovir group compared to placebo. So there was an advantage of adding oral acyclovir. However, this cannot be definitely commented upon because an adequate sample size could not be collected in this study. Now moving on to HEDS 2. In this, there were again 3 subparts. The first one dealt with epithelial keratitis, role of oral antivirals. The second one was an acyclovir prophylaxis trial. And the third one assessed the risk factors for herpetic viral keratitis. So dealing it one by one, first one, that is the epithelial keratitis. These patients were already on topical antivirals and the role of oral acyclovir was compared with placebos in cases of epithelial keratitis. So now it was observed that the risk of developing stromal keratitis or iritis following an epithelial keratitis was almost similar whether you gave acivir or a placebo. So there was no definite advantage of adding oral acyclovir in patients of epithelial viral keratitis. But it was also noted that those patients who had a prior history of stromal keratitis in the background of epithelial keratitis did have a higher risk of developing subsequent stromal keratitis, wherein oral acivir could be considered. The second part was the acyclovir prophylaxis trial, wherein oral acyclovir, the patients who had past history of viral keratitis in the last 1 year but had a recurrence free time of at least 30 days were divided into two groups. One group received acyclovir 400 milligram BD dose, which is the prophylactic dose that we routinely follow nowadays, was compared with the placebo group. Now it was observed that the patient who received acyclovir did show a reduced recurrence, especially for stromal keratitis. The risk of recurrence was reduced from 13% to 8%, which is almost a 50% decline. Hence, it was concluded that acyclovir reduced the probability of a recurrence by almost 50%, especially for stromal keratitis. Now the last part, okay, also an extended observation period was given in the acyclovir prevention trial, where the benefit of acyclovir prophylaxis was assessed beyond the time that acyclovir was given. It was observed that after you stop the acyclovir prophylaxis, the risk of developing recurrences was similar in both the groups, whether you gave prophylaxis or no prophylaxis. Hence, the benefit of acyclovir prophylaxis does not extend beyond the time you're giving the prophylaxis. However, there was also no rebound increase in recurrences after stopping the prophylactic therapy. So to conclude, the oral acyclovir had a benefit effect in reducing the risk of recurrences, and the risk-benefit ratio of impact of disease and cost needs to be considered before you give this prophylactic therapy. And long-term prophylaxis for epithelial keratitis is not something that is needed. The last part is the recurrence factor study, wherein both environmental, psychological, and stress factors were evaluated in the risk of recurrences for hepatic eye disease. The outcomes of this study did not give any conclusive results, and there were no risk factors that were found. Hence, the key points to take from the HEDS study were that for epithelial keratitis, no prophylactic use of oral acivir is needed. For stromal keratitis, prophylaxis can be beneficial. To manage stromal keratitis, steroids can be helpful, and oral antivirals may not have an additional role. Thank you.